Management of Arrhythmias in Infants and Children, an update on medical management and newer advances by Dr. John Roshan. Dr. John Roshan is a professor of cardiology and heads the unit of cardiac pacing and electrophysiology at Christian Medical College, Vellore. He is also the program director for the EP fellowship at CMC Vellore. He completed his cardiology training from CMC Vellore and subsequently completed an adult EP fellowship at the Toronto General Hospital and a pediatric EP fellowship at the Hospital for Sick Children, Toronto. He is on the International Heart Rhythm Board of Examiners to set questions for CCDS and CEPS. He is a recipient of many awards, and he has a great passion for teaching wildlife and enjoys driving on long road trips. So over to Dr. John Roshan.
Good morning to everyone. At the outset, I'm grateful to my good friend, Dr. Lawrance, and the team from KMCH, who has invited me and given me this opportunity to speak to you on arrhythmia management in infants and children, an update looking at the more recent advances. I would like to start my talk by broadly speaking about antiarrhythmics, the acute management of arrhythmias in infants and children, and finally touching upon the chronic management with a brief look at WPW syndrome, which is generally one of the common things that most pediatricians face. So to start off, I thought we'll talk about a patient, and this is a patient by name Aslan Soli, who was born with a total anomalous pulmonary venous connection. Now, this child had a surgery done, and post-operatively, the child had frequent premature atrial contractions with short runs of atrial tachycardia. As a result, the child was hypotensive, and it was very difficult for the child to be extubated. Esmolol was tried and failed. So what do we do next? How do we approach the problem? So when you think of antiarrhythmics, it's important to understand that they are not like cough suppressants, and most antiarrhythmics work by changing the shape of the action potential. So let's briefly look at class 1 drugs, and this is more typical of class 1C drugs like flecainide. As we all know, class 1 drugs affect the sodium channel, and the sodium channel has got two gates. It's got a H gate, which is open during the resting state, and an M gate, which is closed in the resting state and is located on the outside. When you get an appropriate stimulus, the M gate opens and sodium rushes in with the cell depolarizing, and the H gate closes at the end of phase 0 of the action potential, preventing further rushing in of sodium. So this would be a pictorial representation where you can clearly see that in the resting state, the M gate is closed. When the cell gets stimulated, the sodium rushes in, and at the end of phase 0, the H gate closes. Now, when you give somebody a class 1 antiarrhythmic drug like flecainide, it binds to the H gate, reducing the opening, thereby preventing the rapid entry of sodium into the cell, effectively reducing the rate at which depolarization takes place. So your phase 0 of the action potential, which would normally be this steep, the slope reduces and it's not as steep as it would normally be. So this effectively translates to reducing the conduction velocity when you reduce the slope of the phase 0 of depolarization. The shape of the action potential essentially determines the conduction velocity and the refractoriness. So all these antiarrhythmics that we deal with effectively change the shape of the action potential, which means they either affect the refractoriness or the conduction velocity, or they may even affect automaticity. So if you look at the various antiarrhythmic drugs like class 1A drugs like quinidine or procainamide, essentially affect the phase 0, but they also affect the overall refractoriness. Whereas a class 1C drug was like flecainide, what we just described, where you have just the conduction velocity being affected, where you're affecting phase 0 of the action potential. Class 1B drugs, however, are a little different in that they actually reduce the duration of refractoriness when you look at the action potential. Class 3 drugs like amiodarone increase the duration of refractoriness, while class 4 drugs act on the pacemaker cells, which are located in the SA node or the AB node, and they obviously, by doing so, will affect the automaticity. So, of all these drugs, the one drug which sort of is odd is the class 1B drugs, which, like I just showed you earlier, they actually reduce the duration of refractoriness, which means you shouldn't be giving a class 1B drug like lidocaine in somebody who's got an accessory pathway. Because somebody who's got an accessory pathway which is capable of antegrade conduction, you give them a drug like this, there's a high chance that the pathway is going to conduct much faster than it would normally do. And should this patient develop a atrial flutter or atrial fibrillation, it could turn around to being pretty catastrophic. So we all are aware of the fact that most arrhythmias are either reentrant in mechanism or have automaticity as a mechanism. Now, we know the prerequisites of reentry, namely being two pathways, they're connected proximally, distally. You have them differing from each other in their refractory periods and their conduction velocities. So we know that you've got a proximal area, a distal area connected by two pathways, a zone which is inert in the middle. You've got a fast pathway which has a long refractory period, a slow pathway which has got a short refractory period. So when beats come down at a low rate, it tries to go down both pathways and obviously reaches distally faster through the fast pathway, and all is well. However, when there's a premature atrial beat that comes down, a premature beat blocks in the fast pathway, which has a long refractory period, but conducts down the slow pathway, which has got a short refractory period. However, because this pathway is slow, it takes a long time to reach the distal end, by which time the fast pathway is recovered. The impulse then climbs back up the fast pathway, setting up re-entry. So the usage of an antiarrhythmic drug in a patient who's got re-entry is essentially to try to reduce the excitable gap. Now, the excitable gap is the difference in the refractory period between the fast and the slow pathway, because that is essentially the window during which an impulse will block off in one and come down the other, thereby setting off re-entry. So if the impulse blocked down both pathways, there would be no re-entry. If the impulse conducted down both pathways like here, there would be no re-entry. But re-entry results when it blocks down one and comes down the other, which is when an impulse knocks on this area during the excitable gap, which is the difference in the refractory periods between these two pathways. So the management essentially involves giving drugs that would reduce this excitable gap. So you either make the pathways both very refractory, preventing conduction down both, or you make them both slick so that both of them conduct pretty fast. So in order to abolish the refractory period, you would either do this where you sort of increase the refractory period of both pathways, thereby preventing the impulse from going around, or you reduce the refractory period of both pathways, leading to both coming down, and that's the way you abolish this excitable gap. Now, moving on from re-entry, when you are seeing an ECG like this, which is not uncommon in the pediatric population, you sort of have a warm-up, warm-down phenomenon. You have an arrhythmia starting off, very typical of an atrial arrhythmia characterized by automaticity. So when you have an automaticity, you are always thinking of essentially the depolarization is happening during the phase 4. There is a spontaneous depolarization that takes place, resulting in this increased automaticity. So you use antiarrhythmic drugs which actually slow down the phase 4 ion fluxes, and that is particularly involving the pacemaker cells, and the drugs which characteristically do that are like calcium channel blockers. However, it's important to remember that automaticity sometimes involves an inciting factor, some irritant, like you may have a child where you have a neckline which has been inserted way down deep, and the tip of the catheter is actually inside the right atrium, irritating it, leading to automaticity. So that's something to be very wary of. And so in a child who has an automaticity related arrhythmia with warm-ups, warm-downs, just keeps coming on and going off at its own whim and fancy, in that kind of situation, you need to make sure that there's no inciting factor like a myocarditis or a catheter that's causing an irritation. And the drugs that you would use are essentially drugs to slow the phase 4 ion fluxes like calcium channel blockers. Now, the other side of the coin is that every antiarrhythmic is also proarrhythmic. For example, take a patient with a WPW syndrome where you have an accessory pathway, you have an AV node, the impulse can come down both, but this child has no sustained arrhythmia primarily because both the accessory pathway and the AV node are very similar in their properties of conduction velocities and refractive periods. However, you see the WPW and you think that you need to do something about it and you give an antiarrhythmic drug. And now this antiarrhythmic drug may selectively act on any one of them, changing the conduction velocity or the refractive period of one of these limbs, which is either the pathway or the AV node, thereby leading to the creation of an excitable gap, which is a difference between these two. Now, once that is created, you have set up everything ready for a re-entry to take place, and a child who wasn't symptomatic now starts becoming symptomatic. So it's important to note that every antiarrhythmic is proarrhythmic as well. So coming back to our initial case of Aslan Soli, the child with frequent PACs, esmolol was tried and it failed. Amiodarone was then tried and again failed. Finally, flecainide was given and the PAC frequency dropped. And 1 month later, the child on flecainide had no PACs. Now, it's important to understand that as physicians, we don't know which drug is going to act how on the pathway or the AV node. We don't really have a control on that. We don't really know whether it's going to affect which limb of this greater or whether it affects both limbs the same amount. And hence, it's sort of like a trial and error when you give drugs. There's no single mantra that can be utilized towards treating all children. Moving on to the emergency management of arrhythmias. Cardioversion is obviously something that you would immediately resort to when you have an unstable arrhythmia. When you have a child presenting to the emergency and you're not sure what the arrhythmia is, it always makes sense to assume it is ventricular tachycardia and treat it so. However, having said that, ventricular tachycardias are very uncommon in the pediatric population, and you usually would see them only in the setting of myocarditis, or if there is some kind of rhabdomyoma or tumor that's sort of irritating the ventricle, leading to that kind of situation. Having said that, you may see ventricular arrhythmias in children with congenital heart disease, in the single ventricle substrate, in the post-tetralogy of fallow surgery substrate. However, these things are relatively rare. The other form of ventricular tachycardia that is seen includes fascicular ventricular tachycardia, and fascicular VT, as we all know, is response to calcium channel blockers. Moving back to cardioversion. Cardioversion in children is usually given at about 1 to 2 joules per kilogram. And generally, we shy away from cardioversion if we can avoid it. Now, what's the logic behind that is that essentially, cardioversion can result in a huge number of things, like it can cause respiratory depression, it can cause myocardial depression, it can result in burns, it can cause thromboembolism, it can even cause asystole requiring pacing. So cardioversion has its own problems, more so in the pediatric population. And in fact, a recent study that was published in the PACE journal has shown that you can have as much as 5% of individuals developing myocardial dysfunction post-cardioversion. This has been noticed up to about 90 days post-cardioversion. And that is the reason why most pediatricians would shy away from cardioversion and choose alternative methods to terminate an arrhythmia if that was possible. So moving on to the acute management of tachyarrhythmias, primarily supraventricular tachyarrhythmias, essentially, one way to terminate an arrhythmia is to slow down the AV node, because a lot of these arrhythmias involve the AV node. If you're looking at AV nodal reentrant tachycardias or accessory pathway involved tachycardias, which includes the PJRTs, where the accessory pathway is actually a slowly conducting accessory pathway, if you were to block the AV node, you would be successful in terminating the arrhythmia. Alternatively, blocking the AV node would also sometimes help you, giving you a clue as to what the diagnosis is, because if it was an atrial arrhythmia, you would see the run of P waves that would make the diagnosis clear. So vagal maneuvers are something that is utilized, and this could include a carotid sinus massage, placing ice suddenly on the face, inducing a Valsalva, or passing a thermometer up the rectum, sending a Riles tube down the child. These are all things intended to cause discomfort to the child and hence has to be done suddenly and to sort of surprise the child or the infant. And when that is done, it results in a vagal outflow, causing the AV node to block off conduction, resulting in a termination of the arrhythmia. However, it's important to realize that these maneuvers are successful if done early enough after the arrhythmia has started. But if tried late, then there's a profound sympathetic response, and attempting to increase the vagal outflow isn't often successful. So here's an example of carotid sinus massage having been done in a child who's actually been having atrial flutter. You resulted in blocking the AV nodal conduction down to the ventricle, and you can see the flutter waves moving along. The other method that electrophysiologists use to terminate arrhythmias in children is transesophageal pacing. Now, this is an extremely useful method to terminate arrhythmias, particularly when they are reentrant in mechanism, like you would see in AVRTs, PJRTs, AVNRTs, and some of the atrial flutters. Now, transesophageal pacing, as we all know, involves placing a catheter in the esophagus. The left atrium is right at the back, so it's very easy to capture the atrium. Unfortunately, it's very difficult to capture the ventricle in patients, particularly in children as they grow up, because the ventricle is pretty anterior in relation to where the catheter is. So though we can read off ventricular signals, the chamber that we can capture is the atrium, and atrial pacing can be done, thereby terminating reentrant arrhythmias. This is particularly useful in children who have reentrant arrhythmias involving slowly conducting accessory pathways, where you have a large excitable gap, and it's so easy for these children to keep remaining in the arrhythmia, leading to tachycardiomyopathy. And it takes a while before the drugs actually get on top of these arrhythmias, and it's not a good idea to keep repeatedly shocking these kids. And in these situations, transesophageal pacing plays a big role. Adenosine, a drug that we're all familiar with, has a very rapid onset of action within 10 to 25 seconds, given through a vein, and it's very effective. And the dosage is usually 100 micrograms per kilogram, and sequential dosing can be given at 60-second intervals because this drug is very rapidly metabolized. When you give adenosine, you usually terminate the arrhythmia in the slower of the two limbs of the reentrant circuit, which would mean that in an AV-NRT, you would terminate it by blocking off in the slow pathway. In an AV-RT, where the impulse comes down the AV node and goes up the accessory pathway, you're again likely to block the AV node. Thereby, in both situations, your last event is likely to be a P wave. However, it's important to note that adenosine can indirectly terminate arrhythmias as well, and not always by blocking the AV node. Sometimes adenosine reduces the refractory period of the atria or the ventricles, leading to premature atrial contractions or premature ventricular contractions, which can enter the reentrant circuit and terminate the arrhythmia. Adenosine has its own risks, which I will come to shortly. So here you see a child having an arrhythmia, and adenosine was given, and you clearly see a run of P waves, thereby making the diagnosis clear that the child had an atrial flutter. However, it's important to be aware of the fact that when you give adenosine in a peripheral clinic, you should have a defibrillator backup. Take, for example, this child who has come with narrow QRS tachycardia with a short RP tachycardia. You see the P wave popping out here after the QRS. So you're not sure what this arrhythmia is. You assume that it may be an AV nodal reentrant tachycardia, and you go on to giving adenosine. But once adenosine is given and the arrhythmia is terminated, you actually see multiple shades of QRS with varying shades of pre-excitation. You have narrow QRSs, broad QRSs. So this child obviously was having an orthodromic atrioventricular reentrant tachycardia going on with the impulse coming down the AV node, going up the accessory pathway. You gave adenosine, blocked the AV node, but adenosine also reduces the refractory period of the atria, leading to premature atrial contractions, degenerating the atrial fibrillation. So once atrial fibrillation has happened, you're having atrial fibrillation conducting down the accessory pathway and the AV node at varying degrees, leading to this varying shades of pre-excitation. Now, this can be disastrous because once you have this kind of situation, you no longer have the protection afforded by the AV node because impulses are going to come down the accessory pathway over here, and the ventricle is going to be pretty rapidly depolarized if you have an atrial fibrillation going on. This will lead to syncope because of very poor cardiac output. And as you can see over here, the accessory pathway refractory period is really short, leading to such rapid conduction. And this can go on to leading to ventricular fibrillation and death of the child. So remember, when you're giving adenosine, make sure you have a defibrillator available in the rare event that this kind of situation happens. The other drug that can be used in emergency situations for acute termination of arrhythmia is calcium channel blockers. And like I mentioned a little while earlier, they have a big role to play in people who have got children who have fascicular ventricular tachycardia. Intravenous beta blockers, one of the mainstay in managing arrhythmias in children. Esmolol is a fantastic drug because it has a very short half-life. Often children and infants with arrhythmias also have low blood pressures, making the intensivist quite anxious to give an antiarrhythmic drug, which may cause hypotension. However, esmolol is a safe drug because it has a very short half-life. And once you give esmolol, you can gradually up-titrate it and observe what the blood pressure is and decide how well the child tolerates it. Digoxin, though one of the all-time favorites in the past, is essentially the least effective of all these drugs available. However, it's a useful drug to have when the other drugs fail or can be used as an add-on drug. Moving on to further management of supraventricular tachycardias, you essentially have ablation as an option, beta blockers, and calcium channel blockers that can be given for long-term maintenance. Ablation is something that we would resort to only when the child has crossed 5 years of age, because as you know, the chances of vascular complications are much higher when an ablation procedure is done in a child less than 5 years of age. The weight that is generally considered is a child being more than 20 kilos, though there may be situations where you have incessant tachycardia leading to tachycardiomyopathy, not responding to drugs, which forces the operator to take the child up for an ablation earlier. So as you can see in this cartoon, you have an accessory pathway, you have the AV node, and when the impulse depolarizes, it has the option of going down both the accessory pathway and the AV node. However, when you have a premature beat, it's possible that it blocks off the accessory pathway and comes down the AV node and then climbs back up the accessory pathway, leading to the orthodromic AV-RT being initiated. So this cartoon highlights the fact where you have the initial beat coming down both accessory pathway and AV node, and there's nothing happening over here. But when you have a premature beat that comes, the premature beat ends up blocking in the accessory pathway and it comes down the AV node. However, it takes time to travel down the AV node, by which time the accessory pathway has recovered. It climbs back up the accessory pathway, comes down the AV node, and keeps going around in circles, leading to the patient having a tachycardia. So in this situation, what the radiofrequency ablation does is that you map the accessory pathway, and the electrophysiologist identifies the location of the accessory pathway and then delivers a radiofrequency lesion, thereby preventing conduction, destroying the pathway once and for all, and preventing the child from having further episodes. AV nodal reentrant tachycardia involves reentry in the AV node. You have slow pathway inputs and fast pathway inputs into the AV node. And in this situation, you have impulses that travel down the slow pathway and go back up the fast pathway when it's a typical AV nodal reentrant tachycardia. Whereas in an atypical AV nodal reentrant tachycardia, it would come down the fast and go up the slow pathway. So either case, you've got two pathways involved. You need to take out one of them. It's always generally the practice to take out the slow pathway because that's likely to be the lesser reliable of the two pathways. So the electrophysiologist would go ahead and deliver radiofrequency lesion, destroying the slow pathway inputs into the AV node, terminating AV nodal reentrant tachycardia. Moving on from there, more recently, we have cryoablation that has come into India. And cryoablation is a great option in children, particularly when you have a para-Hessian pathway or AV-NRT. So when you have an accessory pathway located right next to the AV node or AV nodal reentrant tachycardia, when you need to take out the slow pathway without damaging the fast pathway. In children, as you know, the anatomy is much smaller. The pathways are closer to each other. You want to destroy the bad guy and you want to leave behind the good guy. And in such situations, cryoablation is a great idea because cryoablation would freeze the pathways. So you reach what you think is the pathway which you need to eliminate, and you freeze down to minus 30 degrees centigrade. And when you do so using liquid nitrogen, it actually will block conduction down whatever has been where your catheter is. And if the two pathways are very close to each other, there's a good chance that at freezing to minus 30, you block conduction down both the AV node and the accessory pathway. Now, when this happens, you rewarm the patient, and when rewarming, the pathway conduction and the AV nodal conduction resumes. So it's reversible at minus 30. So once you've done that, you've got back both conduction, you reposition your catheter, get a better position, and again freeze down to minus 30. And when you do so, if at this time you've got rid of the pathway, but you still preserved AV nodal conduction, then you know you're at a right site where you can preserve the AV nodal conduction. You go down to freezing to minus 70, and once and for all, irreversibly damage the pathway, saving and preserving the AV nodal conduction. So this is the principle behind cryoablation. However, having said that, cryoablation has a higher recurrence rate when compared to radiofrequency ablation. The new kid on the block is electroporation, which is still being investigated and is likely to be the therapy of the future. A brief note on asymptomatic WPDW patients. Essentially, when you have a child or an infant who has an accessory pathway, you need to risk stratify these children. If they are low risk pathways, nothing needs to be done. But how do you decide if a pathway is a low risk or a high risk? So one method is to subject the child to an exercise testing. This can be done if children are slightly older and will cooperate. You should be aware of the fact that during a treadmill, there can be movement artifacts. Also, left-sided pathways are very far away from the sinus node. So often they may be masked and you may not see them conducting very well when you put the child up on a treadmill. However, putting the child on a treadmill can help you estimate the accessory pathway's refractive period. And that is possible if the pre-excitation is abruptly and suddenly lost. So over here, you can see these first 6-7 beats have got clear pre-excitation, and then there's an abrupt sudden loss of pre-excitation, suggesting that at this rate, the accessory pathway doesn't conduct. Using this, we can calculate the refractive period of the accessory pathway, and high-risk accessory pathways where refractive periods are less than 250 milliseconds would definitely warrant ablation or medical therapy. The transesophageal EP study is another great option to study these accessory pathways. You can use the transesophageal EP catheter to induce atrial fibrillation by rapidly pacing the atrium and thereby ascertain the shortest pre-excited RR interval, thereby determining whether the pathway is a high risk or not. The transesophageal EP study can also be used to decide after medications have been initiated as to whether the medications are effective in preventing arrhythmias. And it's also quite common for pathways that have resulted in fetal arrhythmias and arrhythmias soon after a baby is born to regress with time. And hence, you could always repeat an esophageal EP study at 1 year of age. And if you no longer induce the arrhythmia with the child being off medication, then one could safely discontinue the medication, assuming that the pathway has stopped conducting. So if you find the pathway is a high-risk pathway and the child has been having recurrent episodes which are hard to control with medication, leading to cardiomyopathy, then ablation would be the choice. However, if the child was less than 5 years and you didn't have an impending cardiomyopathy, it would always be good to give a trial of medication. The drugs that could be considered would include flecainide, propafenone, sotalol has also been tried in these groups, and that would not be a bad idea. So with that, I finish my talk, and I haven't gone into bradyarrhythmias for want of time, and I thank you all for your patient listening. I'm happy to take any questions if you all have.